graduate who participate workshop in 90 going to be our speaker. So I encourage them to use English. Is that okay? So you can train your ear to listen English. But if you don't understand, just raise your hand and say, stop. Can you repeat? What is that? But because if everybody speak Thai, lecture Thai, you are not going to learn English. You have to force yourself, listen English, think English, translate English. We used to listen English, translate to Thai แล้วก็ใส่เข้าไปในสมอง No good. It have to create a new synapse. Because from now on, in your dorm or in your work, hello, good morning, how are you? In Texas, we say, howdy. How are you? We said, howdy. Okay, Dr. One Pen, why don't you introduce yourself first?
Morning, I'm One Pen Vongchavanish from University of Texas Southwestern Medical Center, and I'm going to be speaking. My session is tomorrow, but my task today is as a moderator and the first speaker. We have a pleasure to have Dr. Napisawadee Vongchavanish. She graduates from medicine in Mahidol Sirat University and did medicine residency in Chiang Mai. Here was actually nominated as the best resident in Chiang Mai, and she did additional training in medicine resident in United States, followed by nephrology fellowship, and she actually joined a faculty at University of Arizona in nephrology division for a while, and now she returns to Thailand and now practice at the Bamrungrad Hospital. And she's going to be giving a tutorial lecture in the nephrology part of the USMLE. So without further ado, I would like to turn the podium to Dr. Napisawadee.
Good morning, everyone. I'm glad to be here and to do my lecture in nephrology.
Feel free to raise your hand and don't be shy because this course is for you. If you don't understand, it doesn't help.
I will start. Can you hear me? I will start with metabolic acidosis, part of the acid-base disturbances. When you see the low serum bicarbonate, you would think whether the patient has either metabolic acidosis or respiratory alkalosis. So this is the algorithm to assess the low serum bicarbonate. First, you will see the arterial blood gas, whether this patient has acidosis or alkalosis. Then if you see that the patient has metabolic acidosis, then you will calculate the anion gap, which I will show you later. Either the patient has normal anion gap or raised anion gap. And these are the differential diagnosis because the disease entity, they are different. Again, the high anion gap metabolic acidosis, you will divide into the kidney problem and the extrarenal problem. Kidney renal origin basically is renal failure, and there are multiple causes of that, or the renal disease like renal tubular acidosis. And extrarenal origin, there are those ketoacidosis, lactic acidosis, alcoholic, and those alcohols poisoning. And if the patient has normal gap, then you would think about the loss of the acid through the GI tracts. So the important part is the anion gaps. And what is the anion gap? So this demonstrates the how you will calculate the anion gap. Basically, it is the difference between the cations, which is the most in the blood is sodium, and the anion is bicarbonate and chloride. The difference, this is the red one, this is the gap. We usually don't calculate the potassium because there's so little in the ECF space, and normal gap is 8 to 12. Talking about the acid loads, you will see there are two main different type of acid loads. The volatile acid basically turns into carbon dioxide, you ventilate it out, and non-volatile acid divided into metabolizable and non-metabolizable acid. The metabolizable acid, they are lactic acid, keto acids, or citric acids, and non-metabolizable acid are sulfuric, hydrochloric, and hydrogen phosphate. And they are different because how they go through the excretion part. So this is the high anion gap acidosis. You will see the list here. Start with the common ketoacidosis from diabetic ketoacidosis or alcoholic. The second one is uremia or renal failure. Salicylic acid poisoning, the patient has aspirin overdose, aldehyde, lactate in the patient who has hypotension or shock. Then you have lactic acidosis, and the patient who has ethylene glycol poisoning, they take antifreezes, then you would develop the ethylene glycol poisoning. So you can memorize this mnemonics. So this is just what I showed you earlier. And those alcohols, they are methanol, paraldehyde, ethylene glycol. Those can develop high anion gap because of those acids retained in the blood. So these are metabolizable acid pathways. You will get the carbon dioxide and water, and you ventilate this out. This is the sodium lactate. And then when you metabolize this acid, you will gain the bicarbonate. So this is important part. So for the non-metabolizable acid that I showed you earlier, those hydrochloric acid or sulfuric acid, then they would be excreted through the kidney only. In terms of ammonia, NH4 or tritratable acid. This is just to show you the benefit of the calculation of the anion gap. When you see the mixed acid base, patient, they do not present with a simple acid base disorder. Sometimes they present with mixed, like acidosis and metabolic alkalosis. So how would you evaluate from the electrolytes that the patient presents? You will see that this patient who develop both metabolic acidosis, for example, the patient who has vomiting, they will lose the acid through the stomach, and they develop metabolic alkalosis. And then later on, the patient become hypovolemia and they develop shock, so they develop metabolic acidosis from lactic acid. Then this patient, you would see that you would calculate the anion gap. Then the patient has the high anion gap, but you would have to calculate the difference between the anion gap of, and I will show you later, if the delta anion gap is over the delta of bicarbonate, meaning the difference from the normal value, then you would think about the combination of the acidosis and alkalosis. So this is the non-anion gap or hyperchloremic. You will see that if the patient has chloride that's increased, then the anion gap is narrow. When you calculate the gap, you would see that there is normal gap between 8 to 12, depending on whether you use the potassium. But most of the time, we don't use the potassium in the calculation. And these patients, they usually lose they have diarrhea, for example, they lose the bicarbonate through the GI tract. Then the compensation of the body would cause the chloride to rise. And this is just to show you the non-anion gap acidosis. You would divide into GI disorder like diarrhea, or you have the pancreatic fistula, whatever happened that you lose bicarbonate. And also the medication that can cause like RTA, type picture. This is acetylcholine, a type of diuretics that has action into the proximal tubules. And the kidney disorder, early kidney failure, that the patient don't have the high anion gap acidosis like uremia yet, and the RTA. There are three different types. And the recovery from DKA, which I will show you later, because this is a common finding that when you see the patient on the wards, I'm sure you would see a lot of the diabetic patient present with ketoacidosis, and after you give them treatments, you will see that the patient initially present with high anion gap acidosis, and then later on they will turn into normal gap because of the loss of the potential bicarbonate, which is ketones in the urine. Okay, so again, the acid enters the ECF compartment, and then it goes through the kidney. So the patient develop acidosis. Just example of the case, patient 18-year-old woman present with 1 week history of diffuse muscle weakness. She is known to use recreational drugs, although she denies use of any drug recently. Physical examination shows a woman with normal vital signs, but she had diffuse muscle weakness. And you see the electrolytes. This is sodium, potassium, chloride, bicarbonate, and BUN, creatinine, glucose, and urine pH you would see here. So we would calculate the anion gap. So this is 128 sodium chloride plus bicarbonate is 120, so the gap is 8, and this is very low potassium. So you will see that the patient fits the definition of normal anion gap acidosis. Okay, and this case actually is a toluene poisoning, which you can see that once in a while when I was a resident, several cases, and this can mislead you to the patient that we think that could have RTA or renal tubular acidosis. But again, the tubular function, they are normal. And why the patient has normal gap acidosis. So I will show you. Toluene metabolized into hippurate, and the hippurate is excreted through the kidney. And because of the hippurate, it's a anion part, and you lose it through the kidney, then it converts the acidosis because you have to replace it with the chloride. So the gap is narrow because the chloride is increased. So then you would see in the calculation that the gap is normal. And when you try to evaluate better, the patient has a renal tubular acidosis. Remember that differential diagnosis of normal gap 1 is the RTA. And when you calculate the urine anion gap, which I will show you later, it would fit like an RTA, but actually it's not. So now it's DKA, which you will see every day. Patient develop ketoacidosis like beta-hydroxybutyrate and acetoacetate, that it will be excreted in the kidney when the normal kidney function. And I showed you earlier that this type of acid is a potential bicarbonate. So when you lose the ketone bodies into the kidney, then you lose the potential bicarbonate, because when it's metabolized in the body without loss through the kidney, then you will regain the bicarbonate. So when you lose the ketone bodies, then you will lose the potential bicarbonate, and you will develop the hyperchloremic acidosis. So this is the real case. The study that published in the New England Journal in 1982, patient came with an anion gap of 28 and bicarbonate of 7 and the glucose of 500. High potassium, which is very common in this type of patient with the hyperosmolarity from the hyperglycemia. Then after you give them treatment, you usually give insulin and IV fluid. Then the patient later on, they develop high chloride, and the gap reduced and bicarbonates is rising, the gap from 28 down to 14, and the glucose is down. So other type of alcohol intoxication that I mentioned earlier, ethylene glycol, ethanol, when patients alcoholic intoxication, they can develop high gap acidosis as well. So how, when you see the patient, you should calculate what we call osmolar gap. This is the formula to calculate the serum osmolarity. You will have to know sodium, glucose, and urea. They are main osmolar agent in the blood. So the 2 times sodium plus glucose divided by 18 plus BUN divided by 2.8, and comes into calculated plasma osmolarity. For the gap, then you would see the difference between the measure, meaning that you send the blood to the lab and then you get the number that's measured. Then you calculate it from the electrolyte, the sodium, glucose, and BUN, then you would see the gap, meaning the difference between the calculated and the measure. And if it's elevated, it means that something in the blood that's raised the osmolarity that you cannot measure, right? So those are the agents that raise the osmolarity in the blood. They are those alcohol. Methanol, ethylene glycol, isopropyl alcohol, which is the rubbing alcohol that we use, and ethanol. So next is, besides diarrhea, is renal tubular acidosis. There are three main types: proximal, which is type 2, distal. Its name says itself, the disorder is in the distal renal tubules, and the other type is the hyperkalemic, distal RTA. The first two types, they develop hypokalemia, meaning low potassium in the blood. But the third type, patient has hyperkalemia. So proximal RTA, these are the features. You will have disorder in the proximal renal tubule. You remember from physiology that the proximal tubules reabsorb most of the substance that filtrates to the glomeruli: glucose, phosphate, uric acid, amino acid, things like that. And also it's a main part of the bicarbonate. The pathophysiology is because they cannot reabsorb bicarbonate. So the patient has has huge loss of bicarbonate in the urine. And also potassium excretion is increased. Therefore, the patient would develop hypokalemic non-anion gap acidosis, and they would lose all this substance. And there's a syndrome called Fanconi syndrome. So this is a part of proximal RTA. And these patients, remember that they don't get kidney stone, and they can develop rickets, meaning the osteomalacia. And you can see this from textbooks. Causes of proximal RTA, that the one that we heard about it is you take outdated tetracycline, and heavy metal poisoning can affect the proximal tubules as well, and many other disorders. So proximal RTA, I already talked about it. You will see there's very rarely develop stones. On the other hand, the distal RTA usually develop calcium stones. Those loss of phosphate like glucose and other defects like amino acid, you would see is common, but that's nothing in distal RTA. Low potassium, and the urine pH, they could be high or low depending on the state of the disease, because you lose bicarbonate. Therefore, you would expect that the patient has high urine pH, right? Because it's bicarbonate in the urine. But when the serum bicarbonate is low enough, then the gradient of the bicarbonate loss is less, then patient can acidify urine, because the site of acidification of the urine occur at both proximal and distal part, and the distal tubule still intact. So you can compensate that. And here we calculate the fractional excretion of sodium bicarbonate. Of bicarbonate, it could be high or low depending on the serum bicarbonate, and not responsive to treatment with bicarbonate, because when you give the bicarbonate, you will raise the serum bicarbonate for a short term, and then because this order is at the proximal tubules, the bicarbonate is lost again. Then the serum bicarbonate is going low again, so it's very refractory to treatments. On the other hand, distal RTA, commonly seen stones, calcium phosphate stone, don't have those glycosuria, phosphaturia, things like that. It could be most of the time low, but you can develop hyperkalemic, as I mentioned. And the urine pH usually above 5.5, because it's distal tubule, they don't work. And fractional bicarbonate excretion is okay, and it's very responsive to bicarbonate replacement. Another patient with 45-year-old woman admitted with fracture in the right femur and with the osteoporosis. Patient has kidney stones 10 years earlier and profound weakness of the legs and hypokalemia. Creatinine is 1.5, sodium 138, potassium low 2.3, chloride 115, bicarbonate 14. So this patient has high chloride, and this is normal gap. You can calculate it. Blood pH is low, so this patient is acidotic. Urine pH is on the high side, 6.0. When the patient has acidosis, usually urine pH should in normal kidney, they should be appropriately low, below 5. And then they give you the urine electrolyte, so then you can calculate the urine anion gap, which is the same. The combination of sodium, potassium, the difference between sodium, potassium, and chloride. And the patient is given potassium citrate, but she did not comply with the treatment. Then you develop, the patient has nephrocalcinosis, and she was treated with Scholl solution, which is a sodium citrate, and with improvement of the muscle weakness and correction of acidosis, because citrate is source of base. This is a distal RTA, causes of distal RTA. So most common cause of distal RTA, the acquired type is autoimmune disease, Sjogren syndrome, SLE, autoimmune disease is most common. And they develop stones, as I show you, and the nephrocalcinosis, meaning that the calcification in the renal tissue, not stones mean the calcification in the renal tubules. Then nephrocalcinosis is the calcification, deposit of the calcium in the renal parenchymal tissue. And distal RTA patient, they develop hypercalciuria, meaning that they have increased calcium excretion in the urine. Then how do you know that the patient has the distal RTA? One way is to test the urine pH. If you see that the patient has normal gap acidosis and a little bit of acidosis in the blood, then the urine pH should be appropriately low, that less than usually 5.5. However, when you try to excrete acid, you can excrete the hydrogen ion in the urine, but it's not much because it would make the urine pH very acid, and then the body cannot tolerate it. Therefore, you have to have a buffer, and those buffers are ammonia. Therefore, in the patient who has metabolic acidosis of any type, you would see that pH is on the low side, like around 5. If it's normal, then you would see lots of ammonia in the urine because you have to buffer the extra acid, hydrogen ion that excreted through the urine. So if the pH is higher and the ammonia excretion amount is low, then you would suspect that the distal tubules acidification function is abnormal. Again, when the patient has chronic acidosis, from whatever reason, mainly either RTA or other reason, this chronic type, meaning ongoing for a while, then the body raises the ammonia production because you have to have its buffer, the hydrogen ion. Low urine pH does not provide information about how much ammonia is present in the urine, because it's two different parts. Hydrogen ion, you would measure through the pH, and ammonia, you have to measure the ammonium excretion indirectly, because direct measurement is difficult, and it will turn into the carbon dioxide in the urine, and we can measure that as well. It's part of the evaluation for the distal hydrogen ion secretion. And so when you calculate the urine anion gap, if the patient has a lot of ammonia in the urine, ammonia is cation, right? NH4+. So when you have the cation, that's high amount of cation in the urine. This is not measured. When you measure the urine electrolytes, then you measure sodium, potassium, and chloride, basically. So you would see the urine anion gap. Let's say if the net charge, meaning that the difference between anion and cation is negative. Let's say sodium 40, potassium 20, chloride 100. So no, I mean 120. The high chloride basically is high negative, high anion, meaning chloride. So then you would see that the high chloride is good because it means that the ammonia in the urine is high, because ammonia is cation and chloride is anion. So that would indicate the chloride would bind with the ammonia, but you can't see the ammonia in the urine. So you would see the high amount of chloride, and the net charge is negative. So then you would, okay, this negative urine anion gap it means that a lot of ammonia in the urine. So again, it's main buffer, and it's a good indicator for acid excretion. However, when the patient is having UTI infection, that bacteria producing the urease, and you cannot, it's not accurate, and you cannot do the direct measurement in the lab. It's difficult. So that's why we evaluate the urine anion gap. So the net charge, the cations, and have to be equal, because calcium, magnesium, they are constant in the urine, and sulfate and phosphate, they are constant. So we left off with only sodium, potassium, ammonia equals to chloride plus 70. So the net charge is difference between cation and anion, and the missing part that binds with chloride is ammonia. And we can calculate the urine osmolar gap as well, similar to the blood, and it can give you estimation of the ammonia in the urine as well. So again, distal RTA and hypokalemic as RTA, because you don't have enough ammonia in the urine when the patient has acidosis. So you would see the urine net charge or the anion gap is positive. It means low ammonia excretion. So then you would think about the RTA. Okay, another type of metabolic acidosis, hypokalemic. Patient presented to the ER, confusion, not able to walk, history of drug abuse, physical exam, blood pressure 120/70 and dropped to 100/70. So the patient developed orthostatic hypotension and tachycardia. Respiratory rate 35. The rest of the exam was normal, except absent deep tendon reflexes and no focal neurological findings. Urine tox screen was negative, so you would think about intoxication when the patient present with this presentation. And this sodium 140, potassium very low 1.9, so you can develop muscle weakness. Chloride is high, bicarbonate 12, anion gap is 18. Blood pH acidosis, right? Normal pH is 7.4, so 7.25 in the blood, it's low. And creatinine, glucose, so you will calculate the urine anion gap and osmolar gap. So the gap is, the net charge is positive despite the acidosis. Therefore, diagnosis was distal RTA. Patient has hypokalemic non-anion gap hypokalemic acidosis with the net charge is positive. So the patient was treated with sodium bicarbonate. By the third day, the bicarbonate is normal and no potassium supplement. And again, net charge is positive. So if the urine net charge is positive, it means low ammonium excretion, as we discussed earlier, or another anion present. That's why the positive charge is high. So this is the benefit of the osmolar gap. They happen to measure the ammonia excretion, which is actually good. When we calculate the urine osmolar gap, you calculate it and you measure it. The difference is 250, so it's actually high. And I mentioned earlier that you can evaluate the ammonium excretion based on the osmolar gap. 50% of this, more or less, would be ammonia. Therefore, this patient actually has normal ammonia excretion in the urine because of the osmolar gap is high, contradict with the positive charge, which make you think that the ammonia excretion is low, but actually it's not. So this patient, initially you thought that they have the patient had distal RTA, but it's not. So again, this is another case of toluene poisoning or toluene intoxication, and toluene again metabolized in hippurate, which is another anion in the urine. So it makes urine charge positive. So it can mimic the distal RTA picture, but actually distal acidification is normal. Okay, so hypokalemic distal RTA, it has to do with aldosterone, because I will show you later in the potassium metabolism part that aldosterone acts at the cortical collecting duct. Then it would regulate potassium excretion in the distal tubules. So high potassium because of aldosterone deficiency, or you have lots of aldosterone but no response to aldosterone at the receptor. And you can see this in the textbook. Basically, aldosterone deficiency, they are either adrenal problem or this long list. Basically, common part is diabetic kidney disease that cause hyporenin hypoaldosteronism and can lead to hypokalemic distal RTA, which we see every day in diabetic patient who has impaired renal function. A little bit impairment doesn't have to be full-blown renal failure. Sickle cell anemia also affects the distal tubule. We don't see that here. Heavy metal poisoning, obstructive uropathy is another one that you can common cause obstruction, and diabetic renal disease. You will see distal RTA with hypokalemic type. Primary adrenal disease like Addison's disease, that would present with the same picture. Drug-induced, commonly non-steroidal, ACE inhibitor, ARB, heparin, cyclosporine, they can lead to hypokalemic distal RTA. Okay, this is aldosterone deficiency. Patient with normal aldosterone, but they take another type of drugs that inhibit the receptor, spironolactone, trimethoprim, amyrolide, trimethoprim. This is in Bactrim. So it can cause the same picture. And acquired disorder, renal transplant is a good example. Then I don't know, you get chance to see patient with renal transplant or not, but when you see those patients, they will sometimes have this picture, especially if they develop rejection. obstruction, again, common type obstruction and diabetic nephropathy. Interstitial nephritis, whatever caused it, there are a long list of causes of interstitial nephritis. With tubular defect, it can cause distal RTA, hypokalemia, salt wasting, ability to concentrate urine problem. Treatments, you correct the acidosis with bicarbonate and you give the diuretics, because most of the time this patient, for example, they have for diabetic kidney disease, they're usually hypertensive and they have high volume. So you give the diuretics, the loop diuretics to increase the potassium excretion, and you give the bicarbonate. Sometimes it's difficult because sodium bicarbonate, it can raise the intravascular volume. It can cause more hypertension. And in patient who has aldosterone deficiency, you would give Florinef is the mineralocorticoid part, so it would help. But again, in patient who has diabetic nephropathy, very commonly seen, they will be hypertensive, and when you give this mineralocorticoid, it can raise blood pressure, so sometimes it's difficult. I already talked about this. Again, algorithm, renal tubular acidosis, you would see whether proximal or distal. Proximal always low potassium, and because loose bicarbonate in the proximal tubules. Distal type, and you will see urine pH and the osmolar anion gap. For when you given arterial blood gas and electrolytes, you would interpret what type of acid-base disorder. This is just to show you there are 4 major types of acid-base. Acidosis, either respiratory or metabolic. Alkalosis, respiratory or metabolic. Respiratory meaning primary increase in the PaCO2, right? Because of the hypoventilation, then you would have the primary increase in the PaCO2, because you cannot ventilate the carbon dioxide out, acute or chronic always. And when you develop acute hypoventilation, let's say a patient come with bronchospasm, asthma, COPD, then you have increased PaCO2 because they cannot ventilate the carbon dioxide out. Then it's acute change, so compensation of the body try to normalize pH, but in acute setting it's difficult because you have to work through the kidney, which takes few days. So in acute, you will change the bicarbonate only 0.1 per 10, about 1 point per 10 delta change of PaCO2. But chronic, meaning happening in a long term or more than few days, like COPD, they compensate it because the kidney have time to adjust, so it would raise the bicarbonate by about 3. So that's respiratory acidosis. Respiratory alkalosis, meaning primary reduce in PaCO2 because of hyperventilation from many reasons, acute or chronic. Same. Acute, you have small change. Chronic, you have more change in the PaCO2. I mean the bicarbonate in response to change in PaCO2 to try to balance the pH. Metabolic acidosis, primary reduce in bicarbonate. As I show you on the first slide, either metabolic acidosis or respiratory alkalosis, both of them have low bicarbonate. But the primary disease for acidosis is the fall in bicarbonate happen first. Respiratory alkalosis, fall in bicarbonate, is happening in response or secondary to changes in PaCO2. And we have the formula to calculate the potential, how the PaCO2 would respond to this. You probably know about the formula 1.5 times bicarb plus 8. That's one formula. Metabolic alkalosis, primary rise in bicarbonate. So high bicarbonate, you would need to increase PCO2 in order to balance the pH. Then that's delta changes of the bicarbonate times 0.7. So that's how you would try to evaluate on the blood gas. This is probably to so common diabetic ketoacidosis after you treat them: hyperchloremic and high anion gap acidosis. DKA present with high anion gap acidosis. Once you give them treatments, then they become hyperchloremic. So the anion gap you calculate is 18. And later on, you see the chloride rising. So the ion gap would getting narrow. And this is one example: acute on chronic respiratory acidosis, let's say COPD. You have chronic respiratory acidosis. When they develop acute exacerbation of the bronchospasm, then you will develop acute on top chronic. You see PCO2 is 80 and pH is low, so it's a primary respiratory acidosis. Compared to this one, pH is also low, but PCO2 is low, so it's primary metabolic, because low pH and low bicarbonate. And this is a table to show you the benefit of calculation of delta bicarbonate and delta anion gap. This column's normal, pH of 7.4, PCO2 40, bicarb 24, anion gap 10. Okay, so delta change 0, so it's normal. So high anion gap acidosis, you see the pH is low. Anion gap's 20, so that's high. Bicarbonate down to 14, and you would calculate the delta change of the bicarbonate. Normal is 24, 14, difference is 10. Okay, anion gap, normal is about, let's say 10, 8 to 12 is about 10. This patient has gap of 20, so delta change is 10. Okay, so this is high anion gap. Anion gap is 20, acidosis, primary. Okay, high anion gap and normal anion gap acidosis is a mixed disorder in one patient. So you would see pH of 7.1, so that's acidosis, right? PCO2 is 20. So primary is metabolic because pH is low and bicarbonate is low. So it must be primary metabolic. Then anion gap is 20, so it's high gap. So when you see this, you will see, okay, patient has high anion gap acidosis. That's simple. However, if you can calculate the bicarbonate change, you see the anion gap is only 10 points higher than normal, but the bicarbonate dropped too low. So the difference of 6 and 24 is 18. So where the bicarbonate go? If the patient has only simple high gap acidosis, you would see this equals. But in this patient, the delta change of the bicarbonate is too huge. This 10 and 18. So the patient must have had another type of acidosis on top of that. So this patient has combination of high gap and normal gap, which can happen in a lot of patients. So benefit of calculation of the delta change of bicarbonate and delta change of anion gap you can see. Okay, another type, high anion gap acidosis and metabolic alkalosis in one patient. You will see pH of 7.38, a little bit on the low side. PCO2 35, bicarbonate 20, so bicarbonate is low. So you think, okay, this patient has some type of acidosis, and you see anion gap is 26. So anion gap is huge. Delta change from normal is 16, but the bicarbonate change only 4. So this patient must have had baseline bicarbonate high, very high. So that's why when the patient develop acidosis, the bicarbonate doesn't come down that much, because at baseline they must have been in the 30. So this patient has combination. When you see the delta change of gap, anion gap over the bicarbonate, then you think about combination or acidosis and alkalosis. So this is the benefit.
Okay, we'll take break at 9 o'clock for 5 minutes, and we will return it in 5 minutes.